Diseases 1. Fibromyalgia is defined by symptoms. There are 3 that are listed. What are they? What can be diagnosed?
Obviously pain.
Pain, what kind of pain?
Pain of the muscle fibers.
Okay, it's defined, so make sure y'all look at that. Anybody know that?
What?
The three definitions for the pain diagnosis for fibromyalgia. Anybody look at it?
The 11 out of 18 too.
11 out of 18 tender points. Give yourself a point. You might know another one?
Good job.
The other one's widespread pain throughout the 4 quadrants for 3 months. And the 4 quadrants would be, different parts of the body. And then the third one is a change in the levels of substance P in the spinal cord fluid. And remember that substance P is a chemical that is responsible for transmitting pain to and from the body and to the brain, from the body to the brain. So a change in the substance P levels.
You said pain, where?
Widespread pain in all 4 quadrants of the body for a 3-month period of time. Tender points, remember those 18 tender points, you have to have 11 of them to be tender out of 18. And then the change in levels of substance P in the spinal cord. Okay? This group up here, what do y'all want?
Let's do arterial.
Arterial wounds, okay. Define eschar. Kind of brown and scab-like, lighter brown. Are you gonna remove it?
Whatever they did.
Right, you don't remove it if it's solid, right? But you do remove it if it's, yeah, if you have some exudate from it, drainage from it, you're gonna need to take it off probably. Normally you do remove it, probably the only time I've ever seen it, well, I take that back, I've seen it on a sacrum area that they've left it, but mainly you see it on the heel of the foot. If it's solid down there, they're not gonna want you to remove that. Okay, good. What would you like?
Wounds.
Wounds. What happens in the proliferation part of the inflammatory process?
That's when they lay down the fibers.
It's a good time, right?
Yeah.
So you have granulation, epithelialization. So the fibers are starting to lay down. How long? Kind of what is that area of time?
7 to 10 days.
I had 2 to 4 weeks. What did she tell y'all?
The thing says 5 to 15 days.
Pardon?
The PowerPoint says 5 to 15 days.
5 to 15 days. Okay. I wasn't in here when she went over that. So, okay. Next group.
We'll do arterial.
Define slick pink. It is pink. Is it a good thing?
No.
It's not good.
I thought it was.
No, slick pink is not good. What else is kind of major about it? Why is it not good? Yeah, it usually means infection, but there's also no granulation, so they've got to address it. So you won't have, remember, if you don't have granulation in your wound, then it's not healing. So there's no granulation, but it is clear, it's just kind of slick looking and even shiny looking and pink. Okay,
Was that the part on the outer edge?
so you can have it within the wound or just on one side of the wound, so yes. Now that would, what, are you talking about the outer edge where it comes over and makes a,
No, it was like, I don't know, it was like almost like really pinky. I don't know.
it's really, it's almost a shiny, wet, flat,
Okay.
just real pink area. And some people think, oh, that looks kind of healthy, but it's not healthy, because there's no
I thought that
granulation.
was where they were skin. Or am I thinking?
Well, it's not healthy skin. You are having some growth. You're trying to heal that wound, but if you don't have that granulation in there, it's not healing. You know, your body's doing all kinds of things throughout this wound process. You get everything to consider. So, anyway. Okay, back there.
We'll do wounds.
Give me the 4 types of wounds. Oh, and she said they're not wounds anymore. What are they?
Injury.
Injuries. Good.
Yeah, we're gonna pass.
We're gonna pass. Yeah, you'll probably make it. Excuse me just a minute. My husband's texting me. I shouldn't even look at it. So you guys know back there? No, just the 4 types of ones that she taught you about. You're making it too hard. There's 2 of them up here.
Yeah, venous and arterial.
Uh-huh.
Alright, got those two.
You got those 2. What was the last one she did at the end?
I just remember lymphadenopathy.
Remember pressure wounds,
Right, okay.
and then neuropathic.
Okay.
The neuropathic, which are just almost circles looking things, yeah.
Okay.
What? You didn't trust yourself and you had all those answers. I'm not gonna jump down your throat. You'll answer them. Okay. Stephanie, what would y'all like?
Yeah.
What happens in the maturation stage?
I wasn't tripping on
Healing, it's rebuilding. It's already been rebuilding.
And what's the time frame on that? 1 to 2 years, yeah. Okay, good.
Was that the
Okay.
maturation?
Part, yes, maturation stage,
Okay,
How long was the proliferation?
1 to 2 years. Would you ask?
No, the proliferation.
5 to 15 days.
I guess we'll do, disease one.
Disease 1. Define multiple sclerosis and tell me what the etiology is.
Okay, it starts virally.
Viral, okay.
Okay, it starts distally and atrophies upwards.
No.
Oh, it has a change in the T or B cells.
Probably does, but it's not a major thing in it.
Okay. Oh, I didn't think so.
Okay, MS, what happens with MS over there?
Oh, it's the crippler of young adults.
That's true, that's a good, yeah.
He's still
You'll be next.
For us,
Uh-huh.
demyelinization.
Demyelinization, so it demyelinates and then you see, what do you see in the MRI?
White spots.
Yeah, like a shiny white spiky area. But it's a demyelinization disease that does not improve, it just scars. Okay, what would y'all like?
Are we getting another?
Or there we just,
I think you should get another one, what would y'all like?
This all day. I don't think that the MS, and stuff is on there anymore. We're not finding the PowerPoint. She said she was able to find it this morning, but she's looking right now and it's not on there.
I don't know why it wouldn't be, but I'll look for it. And see if we can get it back up, if it's not. Define epithelium in a wound.
epithelium and a wound.
What is epithelium?
Oh, it's the, outer skin.
Right, but if it's in a wound, is it a healthy thing or an unhealthy thing?
Healthy?
Yeah, it's a healthy thing.
Is it,
So it's the new pink skin that's
yeah.
developed, it's the epithelium of it. Okay, what would you like? Define granulation tissue.
Granulation tissue is where the scar starts to form.
It what?
The scar starts to form.
No, not really.
Where it has like a covering so it can start healing.
Right, what's it look like?
Is that where microphages come in?
No,
Not a scab.
no. She was real specific on it, was what she told us, because I was in here when she said that.
She said a question.
What is granulation tissue? Is it a good thing? It's a good thing. Pardon?
It's nutrition.
Yeah, it's a hamburger meat. It looks like hamburger meat. Literally has little bumps on it, and it's very healthy, it's very pink looking. It looks healthy. Okay, what would you like, Scott? Venus. What are some of the symptoms of a venous wound? What do you see?
It's wet, it's wetter.
Yes,
not
it's
dry.
wet, okay.
It is irregular shape.
Yes, irregular borders, good.
Is there more swelling?
Yeah, but yes, more edema down in that area.
That's about all.
And kind of what does it look like? Those things are all part of it, but what do you think it looks like?
Looks disgusting.
It does look disgusting.
It was
It's
like
just-
longer,
it's
wasn't it?
patchy. It's, I don't know,
It's like real.
Where's it normally located?
Red.
on the medial malleolus.
Yeah, on the medial malleolus and on up into the calf and, well, in the front part of the leg a lot of the time. But it's usually down below the knee, right? And it's in the calf area and down onto that medial area of it. The only thing, and it's usually a brown stainy looking thing, kind of brown, doesn't look very healthy. Okay. What would y'all like? Disease? Define Charcot foot.
That's when the bones like collapse and it kind of like folds out of bone.
And what disease does that normally go with?
The diabetes.
Diabetes, yeah. If I do that, it's because I don't hear you enough that I'm questioning what you said. Yeah, it's diabetes mellitus, and that's where the ankle bones actually prolapse on each other. They don't have enough support, and there's usually a lot of, the foot looks awful. It looks bad.
Did you say, what was that?
Charcot foot, C-H-A-R-C-O-T, foot. Okay,
Fully disease.
disease. What are the weight-bearing expectations for a total hip arthroscopy? What are the weight-bearing expectations for a total
Is
hip
it
arthroscopy?
touchdown? Or-
No.
Okay. Is it start out as no weight bearing and then go to that?
No.
Okay. Y'all know it?
It's full weight bearing.
Is it?
Is it full weight bearing?
Weight-bearing is tolerated, the total hip. Almost always, again, sometimes you'll have a doctor that'll order touchdown or whatever, and you always do what the doctor tells you to do. But remember that if you put weight on total hips, you can't hurt them by putting too much weight on them, okay? So you kind of expect them to be weight bearing is tolerated.
It's just you can't add that.
Yes, you can't adduct, it's flexion, internal rotation, and adduction. It's this movement right here. Like when they cross their legs, that's when they do it. Pop that thing. I'll tell you, the one I saw years ago, and you rarely see a hip popped out anymore, it's a rare thing, but this lady crossed her legs, and then she bent down to the floor to pick something up. Popped right out. Okay. Are we over here, or are we back here, because y'all didn't know that one? Okay, what is the weight-bearing status or expectations for a total knee arthroscopy?
You didn't pick one.
Oh, you didn't pick one? Well, okay, you got it anyway, what do you want? What do you know?
On that,
Uh-huh,
it's like, what, 3 days or something? What am I thinking of? You said a total knee?
what do you expect to do on a total knee?
Like, within 3 days, they're like more strong. It's weight bearing and tolerated within 5 days, to be conservative, I'd say 3 days.
Yeah, it's weight-bearing is tolerated.
So,
Which means that they can put however much they feel comfortable doing at pain level. So if they're full weight bearing pretty
is it
quickly.
the same for a hip?
For a total hip, yes.
Okay. Just because they're so secure.
Yes.
Cemented in.
Yes.
Okay.
Okay.
Do you want to do either or? Or two. We can try.
Define exudate.
Right, oozing. Is that right? It's the oozing stuff that drips out of
Yeah,
it?
it's just drainage of any kind.
Yeah.
Yeah, okay.
We'll do, number 2.
What is the weight bearing expectations for a ORIF at the hip?
That's I'll say touchdown weight bearing.
Touchdown weight bearing, correct, or non-weight bearing, but touchdown really is non-weight bearing, isn't it? You can't put weight on it, but you can put the foot down. What are you gonna do if you have a patient that can't maintain touchdown weight bearing?
You're not gonna put it in.
So you're gonna let them do non-weight bearing? Okay, that's correct. Yeah. And do lots of upper extremity what?
Exercise.
Wheelchair push-ups. Put them in a chair with arms and get them pushing up. Do 50 to 100 a day. They'll be ready to go in 2 days, maybe 1 day. So they have to be able to push up on that walker to be able to lift their weights. So do lots of push-ups, which is good for them anyway, by the way. If they're not real stable, it's a good balance. Okay.
Arterial.
Define purulent, P-U-R-U-L-E-N-T.
Like pus and drainage.
Yeah, pussy, it's gross, usually smells. Okay,
Who's the number 2? You said it's stinky pus?
just pus, for sure pus, but normally it will smell. Purulent, I always think of smelling, but I guess it's just pussy, but anyway. I'm not sure if smelling goes with it, so I probably should say no, but it's just pussy.
Did she take those pictures?
Oh yeah, those are all her
ones that-
patients.
I can't imagine going and seeing all that and then just being like, okay, it's time for lunch, let me just go eat my.
You know, it doesn't bother me. Some things will get me. I tell you, when I was pregnant, I could not do anything with people. I couldn't mess with dentures. Have you ever messed with people's dentures? They can get really gross. I couldn't do dentures. You have to be careful with dentures anyway, because they get thrown away a lot. And I couldn't do wounds when I was pregnant. But other than that, it doesn't bother me. I can talk about it too. I can talk about it at lunch and it doesn't bother me. So I have to be careful not to do that. See, I don't do that. But anyway, it's, she's seen a lot worse things than I have. I mean, she's been doing this for about 15 years, but these are all her patients.
It's crazy that some people go through that.
Well, it's crazy because it's so preventable. And that's why it's so crazy and sad. Think about, well, you know what? When people get into those really severe pain, they don't have any sensation in those areas. So they really don't those severe injuries in like their hips and things, they really don't have a lot of sensation back there. I don't know how much pain they're really in. Yeah, I don't know. You don't see a lot of pain with those real severe bed sores, by the way. You just don't.
My honest opinion, because I worked in nursing home for like 9 years,
Yeah.
they just keep them so understaffed that there's no way that one person can do the turn schedule every 2 hours to every 6
Right,
hours.
and that's what
And
happens.
it's sad.
You know, it's time to start taking care of our old people. We need to look at that more. We really need to demand that they do some things.
I didn't do my job because I couldn't do everything.
Yeah, and you can. In 95% of the time, you'd be short-staffed in the nursing home. It was crazy. Anyway, okay. What are the 3 long-term residuals of Guillain-Barré that you see commonly? Where are we? I just gave it to you, I'm sorry. You got
we
disease
picked
too.
one. We picked it.
Oh, you did pick it, okay.
A long term?
Uh-huh.
I don't know short term.
Can't they have some lung deficiencies?
They have deficiencies, there's 3 of them. You really haven't looked at this, have you?
I know the short term.
What are the short term?
It's, where they have like a
Proximal
shutdown of organs,
Huh.
and they sometimes can go on a ventilator. Well, I knew a short term.
Really, they don't have a shutdown of organs.
No.
No, it's more like a weakness, a muscle
Okay.
weakness.
Oh, I think
So what's the answer to that?
And they get better, right?
some of them.
Usually they do, 5% of them die. And if they go on a ventilator, their chances to walk are not, 80% of them start walking within 6 months.
Can it reoccur later?
It can,
Just not very.
well, especially if you overwork them, you can exacerbate them, so that's good to remember. But y'all can't remember the 3, does anybody remember the 3 long-term residuals of Guillain-Barré?
Is it the muscles
Okay, it is the muscles, but you have a weak anterior tib, so you have dorsiflexion problems, so they drag their feet. You have weak foot and hand intrinsic, so they don't have fine motor in their hands or feet. And then you have weak quads and glutes, so they have trouble sit to stand. Those are sometimes the last things to come back in. And sometimes they don't ever get back good control in their hands and feet. Oh, let me tell you about this patient I started yesterday. He has been a diabetic for 20 years, and he was out mowing his lawn about 2 months ago, and he kind of felt a pop in his shoulder, and he developed a very severe but infection inside the joint in that shoulder that went over to his other shoulder. And so they had to surgically open him up and clean out all of the pus and stuff and infection in his shoulder. So he's on 2 wound vacs on both shoulders. That's mainly what home health is seeing him for. And when I went in to see him is he doesn't have any shoulder movement at all. He's very weak and very painful. It's very painful. The pain level has decreased quite a bit, but he's lost quite a bit of range of motion in both shoulders. The left one's definitely better than the right, but just real interesting. So what would y'all have done with him? He cannot lay down flat. He's sitting up to sleep, literally sitting up pretty much completely straight because it's been so painful. The pain level has decreased about 50%. So what do y'all think I did with him?
Lower extremities.
Oh no, I went in there for the upper extremities.
Did you do range of motion?
I did passive range of motion on him on both shoulders, so I started with that.
How painful is that?
I did not go above 90 degrees on either shoulder. Actually, I probably did like maybe 100 on that left because it's in much better shape. But the right one's very painful, and I'm a little worried about messing with those wound vacs, so I'm staying at about 90 degrees. He's also decreased in internal and external rotation, especially in the right shoulder. So now what do y'all think I did with him? He can do things at the elbow down. He's pretty strong. I'd say like a 4. But his grip is horrible.
You do isometric.
Yes, I did isometrics at the shoulder, so I taught him how to do that against the door in all different directions. And then internal and external rotation, and then I'm just having him actively do the internal, external rotation at this level.
Is there a name for that type of condition?
I've never seen that in my entire life.
Yeah, I've never heard of it.
And I've talked to some other nurses, and they've never seen it either.
So it happened in one shoulder and affected
And
both?
it went into the other shoulder, and he got infections in both shoulders. Has never had shoulder. I tell you, diabetes does weird things sometimes. When you see some really weird stuff, you think they're diabetic, because it really can do some weird stuff. And he's a young man, he's only 48, so it's kind of a sad thing. So my goal is to just really get him moving again and get him functional, because he can't do anything. But we did, what do you think I did with the hands and stuff? Did a lot of grip. I gave him my little grip ball. I'm telling you, go buy grip balls. They're always, almost everybody needs them. It's rare that they don't if they've been in the hospital. I would say he had a grip of less than 10 pounds in both hands, and he wasn't even aware of it. That was interesting.
That means he's about to die. That's what you said.
Well, if he doesn't, it's amazing how strengthening that grip. I asked him, I said, are you dropping things? And he told me no, he hadn't been dropping like his coffee and stuff like that. But the other thing I did is I put him on 1.5 pounds exercises for his biceps and his brachioradialis. We'll see how he does. I was a little afraid he'd overdo, so I had to really caution him. I'll see him Thursday again, I'll tell you all about him.
Would that not hurt the butt because of the crossover of the?
It could, but he was using those biceps anyway, and they were about a 4/5. So he was pretty, but he cannot push up from his chair. So I just started having him lean on his arms. He could tolerate it on the left but not the right. I just had him start doing some pushing into his arm because of the lack of stability in those shoulders.
Do you ever use hand putties?
I do. I didn't have any, and I think he really doesn't need hand putty because it's not really a problem with his hand working. It's a lack of strength in it. But I could see that. We'll see how the grip stuff does,
So no
because
problem.
sometimes you do need to work on fine motor.
No problem with dexterity.
No, it's just that weakness in the grip, which kind of surprised me because of him. Anyway, okay, where were we? Sorry. Was it y'all's turn? Venus. We stayed away from Venus. Except y'all got both of those. Where are most venous wounds? We talked about this.
The humeral illness and then up to the, below the knee, but the calf area.
Okay. Good, okay.
We'll do Venus.
So what?
Venus.
Venus, okay. What millimeters of mercury of pressure do you need for effective compression?
I don't know why I want to say 100, but I'm sure that's way off.
What'd you say?
I want to say 100, but I know that that's way off. I really don't.
Yeah, that's quite a bit. Anybody know? Anybody remember?
75.
30 millimeters of mercury, and she said most of her patients are between 20 and 30. Why is that? Why can you not start them at 30? Just so, has anyone ever worn a pair of TED hose in the hospital? Those TED hose, y'all have not done a lot in your life, have you? A TED hose is about 15 millimeters of mercury. So it kind of gives you an idea when you're helping people choose garments, because they can literally order compression garments now off of the internet at Amazon. And so it helps you to have that knowledge. So to be really effective, you need 20 to 30 millimeters of mercury, but I'm gonna tell you, most people can't tolerate that. And so I usually have them go below 20 because if they're not gonna wear them, it doesn't do them any good anyway. And they have to be able to put them on. So if they can't put them on, what's the use of them having them? So I do a lot of that.
What was the question again?
How many millimeters of mercury do you need to be effective for compression?
And why did you say you have to start at 20?
Because they can't go up to 30 is a lot. You want to build them up to 30. So remember the 30. Remember the 30. Okay.
DQ, I guess.
It's where not seeing those mouths move. Just telling you. Okay. What is the Charcot's triad and what disease does it go with?
Intentional tremor.
Intentional tremors.
Multiple sclerosis.
What?
MS.
MS. Intentional tremors is one of them. It is nystagmus and a scanning speech. The scanning speech.
It's scanning something, she said.
That's pretty good.
What disease besides?
This is multiple sclerosis.
Oh, is it only MS?
Yeah, it's only a mess. It's a common triad that you see with it. Okay, next.
Venus.
What are causes of venous wounds?
I think one's whenever the valves, allow backflow.
Okay,
Yeah, do you call that venous insufficiency?
venous insufficiency, and that would be the valve swelling.
Okay, something else. Could you say a sedentary lifestyle? Is that even something?
Well, obesity
Okay.
kind of goes with that, so
Okay.
yes, it can be a sedentary lifestyle.
Obesity, okay.
How many more are there?
Well, there's at least one more
Okay.
that she mentioned.
Okay.
What causes swelling in your feet more than anything else, do you think?
Oh, okay, so diabetics, lymphodemas.
Lymphedema.
Okay.
Is it smoking one of them?
Not with venous wounds usually.
Congestive heart failure.
Congestive heart failure, that's the thing I was looking for.
Okay.
So if you have unstable congestive heart failure and you don't have a good regimen to keep that fluid out of there, then you have that swelling in their feet, and then that causes problems for venous. So, good. And then the other one she mentioned was a CTs, but she said it differently. Do y'all know what a CTs is? ASCITIES.
Your abdomen?
Yeah, it's where you have fluid buildup, normally in the abdominal area, and it normally goes with cancer. So a cancer patient will build up with a CT. Sometimes it's other diseases, but for sure you see it with cancer at the end stages. Okay, girls?
Let's see, which one do you wanna go with? Venus? I don't know who this one.
What must the patient be able to do to be able to use a uniboot? Or an uniboot, excuse me, an uniboot.
What must they be able to do?
I'm not sure she even covered this, but I wanted y'all to know it, so I went ahead and left it on there.
It would have to be a lot of things, though.
Does anybody know?
It'd have to be what, right there.
An uniboot?
It'd have to
Uh-huh.
be-
I know what it is, I forgot what it's used for though.
What they have to be able to do.
Uh-huh.
You'd have to be able to
I mean,
wait there, wouldn't you?
That's everywhere, Bear. Not that, yeah.
I mean, you looking for?
That's not the main thing I was looking for, but yeah.
Had a hole in it?
Pardon?
Is that the thing where she showed it had a hole in it? Where the,
No, a uniboot starts, they put medication in it, and they start the wrap at the toe and wrap it all the way up, and they go over about 50% and go up all the way to the up to the knee. And so, it's kind of it's like a lymphedema wrap, but it's got medication in it, and they have really good luck with it, but you have to be able to ambulate to have it. So if they're not ambulatory, then it's not good. Because really, you can develop blood clots from it and things. But they're very effective on wounds. The uniboots are very good. And you leave them on for, like 3 or 4 days. So that helps too, because it covers that wound. The new thing on wounds with surgical wounds is they put a waterproof dressing on it, all your hips and knees now, almost across the board, and you don't ever mess with those dressings for the first 2 weeks. And it's really nice, because you don't have to mess with it. Now, if you have someone that's bleeding, yes, you would change it, or if you had a lot of drainage. But if you had drainage, what would you do anyway? What would you do if you had drainage on a new wound?
Dress it.
You call the doctor. They need to go see the doctor immediately. any kind of wound drainage that doesn't look normal. If someone's bleeding pretty heavily, that should not happen from a hip or a knee. So they probably need to go back to the doctor, go back to the hospital. So it's even, call the doctor, they'll usually say, you come right now. Seriously, that's how they do. But especially if you see some type of drainage like what? What kind of drainage would you be afraid of?
Green?
Green would be really bad. For sure, you probably need to go on an ambulance if you have green. Yellow's bad. If you spit something up, if something's yellow versus clear, now if it's clear drainage, then you're not quite as concerned, but you're gonna definitely watch it. Some people will have especially if they're obese or have some type of lymphedema type issues, you'll see some clear drainage sometimes, but anyway, okay, where are we? I get off on my soapboxes and I forget.
Number 2.
What can you tell me about Parkinson's disease?
They have resting tremors,
Resting tremors,
festering gait,
festering gait.
70 to 80% of dopamine loss in the substantia nigra.
Yes, and where's that substantia nigra located?
It's by the basal ganglia in the midbrain.
Very good, boy, you know that. That's exactly what I asked. Okay. Guys,
Let's get the last arterial.
you're gonna get that last arterial. What are causes of arterial wounds?
Smoking.
Smoking is the biggest one probably. So what does smoking cause?
Like blood flow to the extremities.
And what's that called when you have issues with blood flow to the extremity? Y'all need to know this.
It's not arterial insufficiency.
Yeah, it's close. It's peripheral artery disease, so it's PAD. Okay, PAD. Okay, define exudate in an arterial wound. Pardon? In an arterial wound, what does it look like?
What were you gonna say?
Is that kind of like a yellow fluidy?
Okay, remember the difference between the venous is very wet.
Oh, well,
And it's
so it's dry?
Yeah, so the arterial, because you don't have much fluid in there. And so think about the skin on an arterial, there's not swelling, there's no swelling down there, and it's very dry. So they actually have very minimal exudate. Sometimes you'll have some bleeding down there, but you don't normally have a lot of other stuff coming out of it, okay?
So is it kind of that stringy stuff?
You don't even see that. Well, you could. Yeah, you could have the strip, but it's very dry. I guess is the main thing I want you to know there. Like you could have the yellow slough in there that you have to clean out, but, and do a debridement, but, it's not gonna be like a wet exudate. You're not gonna have much on the bandage. Again, sometimes you'll have bleeding, which is a good thing. If it bleeds, it's a good thing. Okay.
You're trying to keep it.
Yeah. Okay.
So, were you saying, can I ask you a question real quick?
Absolutely.
So you said that the main cause of arterial wounds is smoking?
It's peripheral arterial disease, whatever causes that.
Okay.
But smoking is a real issue with it. Smoking will definitely cause your arteries to decrease their effectiveness. Okay, what, you had number 2. If someone has fibromyalgia, do you see an increase or a decrease in serotonin levels?
Decrease.
Pardon? Decrease, correct. Okay.
I guess we'll take that.
Oh, you got whatever you take. Oh. Okay. I'm not going to even do that anymore. Okay. Tell me something about ALS.
named after the baseball player.
And what's his name?
Lou Gehrig.
Lou Gehrig, good.
And that's about all I know.
Did they find a cure to that?
No,
No.
but no,
It's,
not that I know of. Maybe there's some new stuff though, I don't know.
I think like that challenge that they were doing a couple years ago to raise money,
Yes,
really helped with research for them, I think.
good. We kinda knew about that because we had a student here that was really involved in that.
Awesome.
About making money and
Yeah.
working with that. There was a man who was having really good results, I think, with some of the research that was being done.
Mhm.
Okay,
Is it the one that, can come back, like you can go in remission and then it?
no remission with ALS.
You die pretty soon, don't you?
Yeah, you live about 3 to 5 years.
Wasn't there something about a vent?
About what? A vent, yes. If they go on a ventilator, they'll live longer, because what happens is the diaphragm eventually is affected.
Is it the one that like it goes to your hands and then works up to back to you?
That's it. It starts distally and it moves proximally. So the first thing they notice is foot drop, or they're dropping things with their hands. They don't have control in their hands. And the other thing y'all need to remember is this is one disease where you see fasciculations. Do y'all remember what fasciculations are?
Is it the muscle?
Yeah, that's where it looks like a little, that's the first one I ever saw was on an ALS patient. And so the muscle's dying, and so it's like a little worm is underneath the skin and the muscle, and it just moves up. It's really gross looking because it looks like there's a worm underneath the skin.
Is that painful?
No. No, I'm trying to remember if they lose sensation. I don't think they do. I need to check on that. I'm pretty sure they don't lose sensation.
Did you say it moves?
Pardon?
You said the little worm thing moves?
Yeah, it's like it moves inside the muscle. You just see it kind of go up in there and then it disappears, but it just means that the muscle's dying. Somebody look up on the internet if ALS patients lose sensation, please. So they are the ones who usually have fasciculations. Does that go with upper motor neuron or lower motor neuron?
It said it
Lower.
does not cause numbness, tingling, or uncomfortable sensation.
Say, read it real loud.
It says ALS does not cause numbness, tingling, or uncomfortable sensation.
Okay, so they don't lose sensation, they just lose motor. So it's all muscle related. It's in the muscle and not the, they no longer produce something that the muscle has to have.
What is fasciculations again?
Fasciculations is where it means the muscle is dying, and you'll actually see like a wormy-like thing in that muscle, where I've seen it's mainly in the calf muscle, and it's like it's right underneath the skin, and it just means that muscle is dying.
Where do you see that on like an MRI?
No, you see it on the patient. Like,
Oh.
they might be walking and all of a sudden they stop and you see this thing in their calf. Or they may be sitting down and you'll see it. I've actually never seen them except in the calf, but I'm sure they have them in their, like their muscles in their arms and things. Okay, where are we at? Which number? Rosie, is it you guys? Define sensation in the area of the hand for the radial nerve, ulnar nerve, and median nerve.
The radial is the back. The ulnar is the median half, and the median nerve is the lateral half. Is that backwards?
Show me on your hand.
So like radial.
Okay, so radial's the back part here, and through what?
Huh?
Through half that ring finger, right?
Yeah.
So that's the sensation of the radial nerve.
And then the ulnar is the pinky, this and like half of the middle finger.
Yeah,
And then the other part is the median.
okay. So the median and the radial sensation, what's the word I'm looking for? Mimic, not mimic, but mirror, mirror each other on the front and back of the hand. And then the ulnar nerve does half of the ring finger and the little finger on both sides, okay? But when you think motor, it's different. Motor, with the radial nerve, full extension on everything, right? So it does the whole back of the hand motor-wise. Remember that's your, this is the work of which nerve? Median. And what's the work of this? Ulnar, and then your interossei and your last two lumbricals. Okay? So motor and sensory are different. You gotta separate those out or it'll mess you up. It still messes me up sometimes. I have to think, oh yeah, that's front and back on sensation for the ulnar nerve. But just flexion, as far as the movement of the fingers go and then the lumbricals. Okay. Who's next? Okay. What is the first thing you always check for hand rehab and treat?
Is it checking if they can feel like the sensation and everything?
Not necessarily feel sensation. You're past that and you're treating them. What do you check what do you treat first on every hand patient that comes in?
So it's like, is it grip or anything?
No, we're not doing an evaluation, we're treating them. Does it come to anybody? It's hypersensitivity. You're always going to check for hypersensitivity and usually treat that. Sometimes you desensitize for 30 minutes of your treatment. Because a lot of times in your hand, a lot of your pain will be a hypersensitivity and you can't work it out. It's just kind of a weird thing. Where else do you do that? Where else do you desensitize? In almost every surgical patient you have. You're going to check for, on a scar. Your eye's going to look for hypersensitivity of a scar. So that will make you a better therapist. If you forget to do that, you're going to miss something. Because so many of them will still have, I think I've told you, I've had a number of patients that still have pain and it's because of the hypersensitivity.
We did some scar massage on a lady. She lost her left carotid artery.
She lost it?
Well, she got in a machine accident. And
Oh my.
And she doesn't have one.
So they cut it out.
She showed me pictures. It was crazy.
I would have to say that woman was meant to live. The chances of her living, I mean, someone had to be there immediately to treat her.
She said if her husband hadn't been there to like put pressure, she would have died.
She would have died. Wow.
And that happened in March, and she's already like so much better. She had like all kinds of stuff, and like at first she wouldn't let anybody touch her. Like it was bad, but she.
Some of that would be fear, just of people hurting you, I would think. But she was hypersensitive.
Yeah.
So you saw it firsthand, how it really can affect your treatment.
It was just crazy to me. And like seeing those pictures, oh my goodness, that was so.
So she showed you after
Yeah.
they sewed her up or
No,
initially?
like when it was still, like when she was in there.
Bleeding from it? Oh my
When she had
God.
just got to the ER.
Y'all realize that in this day and age, we take pictures of really gross things sometimes, because we all have a camera with us, right? So let me just take care, I know you're gonna die anyway, but I'm gonna take your picture.
I can't believe this.
Okay, next, is that you back there? How long is a total hip arthroscopy normally on a walker?
weeks.
2 weeks? I would say probably the best answer you could have is, depends on the doctor and what he orders.
Right.
Some of them are very conservative and they're gonna make them stay 6 weeks.
That's, yeah.
And then
it was,
others are gonna let them go to a cane in 2 weeks. But 2 weeks is, for sure, they need to be on it for a minimum of 2 weeks. Why?
Risk of fall.
If they fall, that's how they're gonna screw that up. The same way with the knee. The only way you can screw up a total knee is to fall on it. You can't put too much pressure on it, you can't bend it too much. You can't do a range of motion on it, you can't pull it out. You're not strong enough to do it. But if they fall, and they fall kind of crazy on that knee, or hit the kneecap. I had a lady fall flat down on her knee, she was a bilateral knee patient, and it dislocated the kneecap on it. She had trouble.
I think with our knee patients that we saw, most of the doctors had it for 6 weeks.
6 weeks. So I would tell you conservatively, they're gonna say 6 weeks, and they're more, and I'll tell you what you'll find with your orthopedic guys, if you work with them a lot, that if something happens and they have a hip pop, or they have someone that injures a surgical area, they become very conservative with every patient again. So they'll go all the way back to being conservative with every patient. And so you just have to listen to what they say, because definitely you do what the doctor says. That is always the truth. Okay, let's see what else I have on here.
What was the answer to that question, Ms. Alden? Did you just want to put 2 to 6 weeks?
6 weeks, put 6 weeks. Normally 6 weeks. Okay, what is hypergranulation? She saw you some great pictures. Who's next? You guys up here. Hypergranulation.
Hypergranulation would not be an excessive buildup, kind of like, not a scar, but before a scar, right? And it's like, it moves off of it.
That's true. That is what it is.
It is what it is.
Yeah, it's an overgrowth around the area, and so they're gonna try and get rid of that. You know, it's too much granulation tissue. Hypergranulation, that's what that means. So it's kind of above surface over the growth. How do you treat it? Didn't she tell y'all how to treat that? What does she do?
Is it whenever you like went underneath it and kind of?
No, that's a little bit different than hypergranulation. But hypergranulation is not healthy.
Don't they use that cauterizing?
She uses that silver nitrate. What I noticed about her, she doesn't do a lot of debridement. I don't know if y'all realize, but she rarely debrides. She uses chemical debridement, and she'll tell you more about that next Monday. But pretty much she does that, where some of your other wound care nurses do a lot of debridement. But she doesn't seem to do that. She mainly uses chemicals to debride. And so silver nitrate is what she would use for hypergranulation. If a wound is too wet, what does it look like?
White.
It's white. And what is that called? What's it called when it's too white and too wet? Maceration, good. Okay, we just need to go through these because we're going to run out of time. Define slough. Okay, define slough.
Oh, us, okay.
Yeah, good job.
So, it's like yellowish white.
Right, that's that stringy stuff. It's really pretty yellow, and it's usually dead tissue. Okay? You guys over here, how do you measure a wound?
Length, width, depth.
Right? And she does what?
She uses the clock method.
She actually doesn't use the clock method, but that's probably the more common, where you do a 12 to 6 and you do a 3 to 9. That's the clock method, and then do a depth. What she does is she goes to the area that kind of follows that, that's the widest. So like it not in necessarily in the middle of that, but she's going to go to the widest length and the widest width. And that's what she measures. As long as you're consistent, it doesn't matter, right? How often do you think you remeasure a wound?
Every time.
Well, probably do it every time. Actually, people don't do it every time. They usually do it like every 2 weeks, I think.
Seems like she said that like it can change drastically within one day, so I would think they would do it every day.
Yeah, especially if they see a drastic change, they will. Especially if they're dressing it. If they're dressing it every day, I'm gonna tell you they're not measuring it every day. But if they're dressing it twice a week, probably so. What is tunneling?
What was the question?
Tunneling in a wound.
And then it's under the skin to the neck.
Yeah, it kind of, and do you measure the tunnel?
Yeah.
How do you do that? Okay, so you stick a Q-tip down in there and you use your little pin and you measure the skin area and measure it, and then you come back out, and that's pretty gross. That's pretty gross. Okay, what color is Pseudomonas?
Never heard that word.
How do you spell that?
Is that the green stuff? It's green. You open up the dressing and it'll be green in there, and it will smell. It has a certain smell. Once you smell Pseudomonas, you'll know it wherever you go.
Is that what you said, once you smell it, you'll never forget?
Yeah, you'll never forget. Well, there's a few others I believe she was talking. Lymphedema was what she was talking about. But that's true. Pseudomonas is that way. Define intermittent claudication.
Pain in the neck while exercise.
Pain with activity, really, but exercise for sure. Then what happens?
It goes away.
It goes away if they sit down and they get up and they do it again. What is causing it?
Is it not giving enough oxygen?
Not enough oxygen because there's not a good blood supply to the legs. Okay. This normally goes with what type of issue? Intermittent claudication goes with what type of
Peripheral
problem?
vascular disease.
Vascular disease, peripheral vascular disease. Symptoms of an arterial wound. And where are they normally located?
The web space or the toe?
Okay, down in the foot, a lot of times in the lower leg or foot, around the ankle. Web space or toe is a good place for them. What do they look like?
Irregular. They're right.
They're a little more regular. The irregular really goes with the venous, so make sure you get that separated.
They're dry.
They're very dry. What else? What happens to the skin around the area?
Lose the hair.
Hair loss?
Shiny.
Looks shoddy?
Shiny.
Oh, shiny. I thought shoddy. They do look shiny because there's no hair, and what color are they normally?
Pink.
Pretty pale. Probably not healthy pink by any means. Is the leg cold or hot?
Cold.
What happens to the nails? They look yellow and thicken. Okay. Define rhubarb. R-U-B-O-R.
That's when like the blood rushes to the foot.
Yeah, it's where you get red and purple coloration in the feet because the blood goes that far. What do you do to get rid of rhubarb?
Don't use a blow dryer.
No, especially for cold feet. Was that a reality though, to no sensation in people's feet, and why you need to do a lot of education on wearing shoes everywhere they go? Even at home, they really need a good pair of shoes on. Okay, especially in some of the homes I go in.
So rhubarb
That haven't
is the
been
color?
cleaned in months. Rhubarb is a red purplish color that happens when legs are hanging down, and it happens more with venous wounds.
So how do you get rid of that?
You elevate, and then that just kind of
Would it
comes
just
back
come
out.
back whenever whenever you started walking or whatever?
It helps to walk, because that can help too, because any of that movement, muscle movement, helps with lymph control. Is that what you're asking me?
Like, would it come back as soon as you put your leg down?
Yes, if you didn't do something to want to keep them elevated.
Is there intermittent claudication on both sides, or is it just one?
It would be both, and that's not always true. Sometimes people do have more problems in one leg than the other, so sometimes that does happen. What is a Doppler? If you think Doppler, what's your first thought if someone's having a Doppler?
Isn't it kind of like an ultrasound?
It's an ultrasound type thing for what?
Clots.
Blood clots. So they're going to measure the arterial supply to the extremities, so that's a Doppler. So you need to know that kind of goes with blood clot treatment. Define capillary field with arterial wounds.
There isn't any?
Very slow and very limited, so yes. What do you do with a tunneling or a wound as far as packing it? How do you pack it? You pack it real tight and hard and really put medicine in it and do it pretty thick, or do you loosely pack it?
It can't grow, right, or it can't heal, right, because you packed it too hard.
Right, so you loosely pack it.
Loose pack.
Loosely packing in a tunnel or into an area that you're feeling. You want it to be loose, you don't want it to be hard in there. How often do you do a treatment change for wound care? On a kind of a standard thing. You're going to change it if you see problems immediately, but how often?
3 times a week.
Every 14 days, every 2 weeks. You got to give this stuff a little time to heal, okay?
Just the dressing, change the dressing?
Not dressing change, but change in treatment, like you're changing to another medication to work on it.
I have a question about the violet stuff that she was talking about.
Could you use that for acne? Cause she said it draws stuff out, right?
It would be a very expensive acne treatment, but I don't
We used to
know.
sell it at the pharmacy.
Ask her when you see her Monday, what she thinks about that. Okay, so we did all that. Anything else? You do need to be able to stage wounds. There's a couple of stage pictures that you're gonna see. So what's a stage 1 wound? It's just redness, there's no breaking down. What's a stage 2?
Partial skin breakdown.
Partial skin, so you're gonna see some blistering. A blister would be considered a stage 2. What is stage 3?
Fitness?
It's through the first layer of skin. And what's stage 4?
Down to the bone.
Down to the bone. So it's down into the bone and tendon. So that's a stage 4. What's the hardest one to stage?
That scars a lot.
Actually a stage 3. It's just hard to figure out if it's a stage 3. There are some that are not stageable. That's what y'all are talking about. Some of them are not stageable, and that's just what you want to put down, is not stageable. What is betadine used for? In a wound area. We used to put betadine on everything, guys. It was crazy.
That's like to clean it, isn't it?
Yeah, it's to debride. It kills tissue. It's a debridement. Okay, define induration.
What?
Induration. Y'all had that in medical terminology, because I teach it.
Can you use that in
It's where you have hardness around edges. There's hardness. It's a hard. Induration means hardness. Why do you no longer use gauze? This came from actually my other wound care person last year. They're finding that it is not a clean barrier for bacteria. It's got too much, allows too much in. Just so y'all know that. It won't be on the test. I was just looking at this. I made this up last year. What has to be debrided from a wound?
The dead skin.
Dead skin, which is called what kind of tissue? Necrotic tissue. What must you have to have? Oh, y'all don't know any of this yet. Okay, we won't have that on there. We talked about. Okay, there's your test. That was a good little Jeopardy. I okay, I need to redo it a little bit, so, yeah, I mean, it's